Bismillah ar-Rahman ar-Rahim. In this video, I will speak about the vitamin D and calcium importance. So these are the objectives of the video. We will start with the history of vitamin D. Historically, vitamin D had been identified as an essential element for bone health only. It was first described in the 17th century. Between 1910 and 1930, a major breakthrough in understanding of the nature of vitamin D as a fat-soluble bone vitamin against rickets, present in cod liver oil, and we can take it from the light. So light at that time equal vitamin D. In 1930, a German scientist had been granted Nobel Prize for his major work on vitamin D. Why is it back? Recently, vitamin D had been identified as a regulatory hormone working on the whole body. Recent researchers identified the molecular structure of vitamin D varies in a similar way to the steroid hormones. Moreover, its target organs had showed a specific receptors, what we name vitamin D receptors, receiving the vitamin D. These receptors were found on more than 9 organs than that required for only calcium homeostasis. That was reported by the end of 2007, where the Time magazine had listed the benefits of vitamin D as one of the top 10 medical breakthroughs of the year. And since then, if we review the literature, we will find that there is an ascending curve in the papers and the researches published on the matter of vitamin D. Going through the physiology of vitamin D, we have two forms of vitamin D, or two sources or types of vitamin D, D2 and D3, ergo-calciferol and core-calciferol. The vitamin D2, it comes from vegetable sources, while vitamin D3, it comes from our skin when exposed to ultraviolet rays type B of the sun. Both are present as an oral supplements. When these vitamin D2 and 3 enters our body, they are subjected to two phases of activation. The first phase in the liver to 25-hydroxy vitamin D, and finally to the second stage in the kidneys, where they are transformed to 1,25-hydroxy vitamin D, which is the active form of vitamin D. Looking at the key concept that fueled vitamin D rebirth was a better understanding of the relationship between vitamin D and the parathormone. If for many years, the scientists were looking for vitamin D level that causes symptoms or skeletal manifestations like rickets or osteomalacia, and that value was less than 10 nanogram. But Chapwe took a different approach. He looked at the relationship between the level of vitamin D and the level of parathyroid hormone, and he noticed that there is an inverse correlationship exists up to a level of 30 nanogram. So levels of vitamin D more than 30 nanograms will not cause any further suppression of the parathormone gland. And accordingly, different terms have evolved, like the term deficiency, in which you have a bony disease like rickets or osteomalacia in a value which is less than 10 to 20 nanogram. And 30 nanogram, that's the optimal level, which is maximally suppress the PTH gland. and a term in between which identifies a suboptimal levels, insufficiency, and this is not associated by skeletal manifestations, it's associated by other extraskeletal manifestations or problems. These are newer terms and classifications coming from different parts of the world, classifying the deficiency into severe deficiency and mild or moderate deficiency. So below the level of 20, you will have a bone disease. From deficiency till sufficiency, an insufficiency of the vitamin D will be present, and this will lead to an extraskeletal manifestations. And from 30, that's the optimal level. Toxicity varies from 80 and more. If we look at the new terms, we will discover that the vitamin D insufficiency level is prevalent in populations, in different populations across the globe. So nowadays, we believe that vitamin D has several reported benefits. Besides its essential role in bone health and calcium regulation, it has an important function in regulating the immune function. Especially in orthopedics, it's of an important concern for us in periprosthetic infection. In cardiovascular diseases, diabetes, mental illness, for us as an orthopedic surgeon, it plays a very important role in prevention of falls and fractures. It provides a good muscle function, healthy bones, as well as it minimizes the risk of orthostatic hypotension. For the risk of fracture reduction, that was reported by a good meta-analysis after proper calcium and vitamin D supplementation in this paper, as well as many international representatives has supported the role of vitamin D and calcium for fracture prevention, like the IOF, the American Association of Clinical Endocrinologists, as well as the Institute of Medicine. Testing for vitamin D. For whom? For the population at risk. For example, the patients suffering from decreased intake, like having a limited sun exposure or a malnutrition syndrome, or having a problem with the absorption of vitamin D, like the patients doing a bariatric operation, or having a problem with the activation of vitamin D for the first stage or the second stage, anti-epileptic medications, or the patient suffering from liver failure. Several reports advocates that aging itself leads to deficiency in vitamin D activation in the kidneys and problems or diseases like nephrotic syndrome or renal failure. So which test should we ask for? We have to understand that the ingested or cutaneously vitamin D or 2 or 3 produced vitamin D, they are rapidly converted in the liver to 25-hydroxyvitamin D. However, only a small fraction of the 25-hydroxyvitamin D is converted to 1,25-dihydroxyvitamin D in the kidneys. So, most of the vitamin D present in our body is after the first activation, and that's why we always ask for measuring the 25-hydroxyvitamin D. Other cheaper tests may give an indirect answer on the level of vitamin D, especially the level of PTH in blood. Usually, in cases of deficiency, the PTH level is elevated above normal, but in cases of insufficiency, we have a high normal PTH level. Other bone markers like alkaline phosphatase may detect or may reveal, may be elevated in cases of severe deficiency. Normal calcium and phosphorus is usually there, except in severe cases where secondary hyperparathyroidism had occurred. Prevention and treatment. Several reports coming from different parts of the world had pointed out that regular diet is not a sufficient supply for vitamin D. Our food is deficient in vitamin D. Asking the patient for proper sun exposure is not a realistic option due to several reasons. On the other hand, vitamin D supplementations is safe and cheap. These are our recommended doses of adequate calcium and vitamin D intake from our orthopedic literature. To maintain a normal value between 30 and 80 nanogram per milliliter of vitamin D in blood, the recommended daily doses varies from 800 to 1000 international unit. A therapeutic dose of vitamin D of 5000 international units per week for 2 to 3 months is recommended for vitamin D deficiency or insufficiency. Men aged between 50 to 70 years should take about 1000 milligrams of calcium supplements per day. However, older men and women aged more than 50 should have a supplement of 1200 milligrams per day. The same maintenance dose is advised by the IOF. However, they recommended higher doses up to 2000 international units in obese, osteoporotic patients, patients suffering from limited sun exposure, and patients suffering from malabsorption syndromes. So, which type of vitamin? D2 or 3? Both are available in the market, and both works well. They both increases the level of vitamin D. The only difference between them that vitamin D3 may have a longer half-life. So in conclusion, use vitamin D if infrequent intake. Important information during prescribing vitamin D and calcium. Remember that vitamin D is a fat-soluble vitamin, so ensure its intake after a meal containing fat. The maximum amount of calcium absorbed in a single dose is 600 milligram. So if you're prescribing more than 600 milligram, prescribe it on 2 separate doses. Acidity is very important for calcium absorption, and patients taking PPI have low gastric acidity, so rely more on the acidic calcium citrate. Thiazide diuretics, lithium, and low sodium diet decreases the renal calcium excretion. Finally, vitamin D deficiency will lead to a decrease in the absorption of the calcium ingested, up to 10%. Please be aware of the new reports coming from the cardiovascular specialists warning against excessive calcium intake causing calcification in the heart valves and the whole body vessels. This may be due to excessive calcium intake, especially that our diet is rich in calcium, and taking calcium supplements may cause hypercalcemia. The second thing is that in our population, for unexplained reason, if you reviewed the laboratory investigations of the calcium level in blood, even in vitamin D deficient patients, you will find it almost normal. So, our new recommendations in our community is that prescribe regular maintenance doses of vitamin D because most of our population lacks sun exposure and are deficient in vitamin D. However, do not prescribe calcium supplements except in patients with laboratory investigations showing hypocalcemia. And for maintenance, only rely on high calcium diet. What about the toxicity? This is extremely rare. The lowest reported level is 80, and vitamin D toxicity itself is not present. However, its toxicity comes from hypercalcemia and hypercalciuria. So, in summary, vitamin D, it's not a vitamin, it's a hormone functioning on more than 50 organs. Deficiency level is less than 20. Insufficiency level is less than 30. Normal is between 30 and 80. For lab testing, ask for 25 hydroxylated vitamin D. For vitamin D deficiency, prescribe the therapeutic dose of 50,000 international units per week for 2 to 3 months. Maintenance doses is between 1,000 and 2,000 international units per day. Prescribe preferably with fat in a meal. The maximum absorption of a single dose of calcium is 600 milligrams per dose. Thank you.